I know we have a lot of great content to cover today. So I'm really excited to introduce Tess King, Nina Tan, Megan Williams, and Addie McClintock today from the Women's Health Pathway. Yay! They are going to be spending the day with us doing a thematic day that they're calling Hormones Across the Life Course, and they have a bunch of great cases and things like that for us to discuss. So with that, I'm going to turn it over to Nina, who I think is doing the first portion of our talk.
Hi everyone, it's Tess and Nina here. We also have Addie McClintock and Megan Williams are joining us quasi-remotely as well to sort of be our attending help as well. So Nina and I have basically 6 different little vignettes, and we're gonna try to cover a lot, but bear with us and stop us if you've got questions. But we're basically gonna follow the life course of hormones, and we're going to be taking you through our case with the lovely patient Moira Rose. One other thing we just wanted to address at the beginning of this talk is that we're often using the word woman, and in that case we're sort of using it to mean cisgender women, mostly because that's what a lot of the research and the guidelines are based on. But we just wanted to call attention to the fact that there's still work to be done for transgender women and people along that gender spectrum. So just want to call that out, that we are definitely a little bit, we're not giving a full picture. Great. Nina, we'll take it away. Okay, so let me just share the screen. Can everyone see my screen? Yes? Okay, cool. Okay, so roadmap for discussion today. So first we're going to talk about contraception, preconception, counseling, and abnormal uterine bleeding. And then Tess will talk about breast cancer screening, menopause, and osteoporosis. And we'll have some breaks sort of built in between. Okay, so let's get started. So first, for our objectives for contraception, we're going to hopefully by the end of the discussion be able to identify a patient's reproductive health and family planning goals, provide contraceptive counseling to guide patient decision making, and then also apply evidence-based guidelines to contraceptive management and counseling. So first, meet our patient. This is Moira Rose. She's a 21-year-old woman establishing care with you, and her intake form lists the following. So her question today is that she wants to start birth control pills, and she does have a history of migraines without aura. She takes ibuprofen monthly for dysmenorrhea, but otherwise no other medications. She does drink alcohol. She uses edible marijuana, otherwise doesn't smoke tobacco or chew tobacco. And she's sexually active with one male partner, occasionally uses condoms with no history of STIs, and has never been pregnant. So in thinking about how to address her main issue today, or what she came into you for today, I just want to offer a framework sort of based on some evidence that shared decision making actually improves patient satisfaction with their contraceptive method. And so people who note that they felt like there was shared decision making throughout their encounter were more likely to be satisfied with their method, and presumably maybe more inclined to sort of adhere to that method as well. So when thinking about shared decision making, there's just a couple, I sort of tried to break it down into 2 separate buckets. So there's the patient-centered factors. So thinking about what are this patient's reproductive goals? What are they, are they interested in pregnancy at all? If so, what's their timeline if they have one? And then what sorts of things are they looking for in their contraceptive method? And then secondly, what medical factors do we need to consider and sort of help educate the patient about? So whether it's they're maybe on some high-risk medications, or there are some contraindications to certain types of contraceptive methods. So here, just listed out some characteristics to consider when discussing contraception. So effectiveness, of course, that is oftentimes what people are most concerned about, but it's not always their first priority. And then frequency of use. So are you able to take a pill every day? Do you feel like you just want to, have something and not worry about it? Sometimes people are less inclined to get a procedure. So for example, the next one on our IUD, just thinking about different types of methods, those are going to be a little bit more invasive. It's just a simple office procedure, but still sort of makes people uncomfortable sometimes. And then how long will it take to return to fertility? So there are some methods that take longer than others. And so if that's a consideration for a patient, then we can take that into account as well. What types of side effects might we expect, and what are the non-contraceptive benefits? And so just some examples of open-ended questions, or just like the language that might be helpful in situations like this. So for example, do you have a sense of what's important to you about your birth control method? And then also just highlighting that there are non-contraceptive benefits. So in addition to preventing pregnancy, there are birth control methods that have X, Y, and Z. Would you like to know more about that? So sort of less directive and more engaging the patient in this discussion. And then also discussing reproductive goals with just an eye towards avoiding any assumptions that pregnancy intentions may not be binary. It may not be, yes, I want to get pregnant. No, I don't want to get pregnant, especially with women who are maybe younger. Maybe they do or don't want to get pregnant initially, and then things change later, or maybe they're just totally ambivalent about it, which is also okay. So I think rather than trying to pin patients down with to try to figure out an answer, I think we can work with some of that uncertainty, as long as we're talking about risks, benefits, and sort of reassuring them that we are partners in their health, and we can be there every step of the way. So again, some examples of language. Do you think you might like to have children at some point, or more children at some point, just to sort of set the stage and open it up for discussion? And then also, what are your thoughts about becoming pregnant now, or in 1 year, or in 5 years? So this is a little bit more closed-ended, just if you feel like you need a little bit more guidance there, giving them a timeline to think about. Okay, and then I also just want to acknowledge that historically it's been problematic, this history of sterilization in women of color, especially in Black women, for sterilization, and that there are still lasting effects of that. I've been in patient encounters where that has come up as an issue when discussing contraception, and so just being aware of this and thinking about, or just sort of antenna up for not using sort of coercive or language that might be perceived as coercive, or sort of holding off on any biases that we might have. So for example, I think that as medical professionals, we often think what is the most effective treatment here? And so of course it's IUDs and Nexplanons, but there's just a really unfortunate history with long-acting reversible contraception and how it's contributed to racial disparities. So making sure that we are sort of checking our biases at the door, I think is an important point in contraceptive counseling. So back to our patients. Our patient, this is, again, Moira Rose, 21-year-old woman with migraines without aura. She has a couple of goals that were elucidated during your conversations. She wants to complete college before considering becoming pregnant, but otherwise doesn't really have a timeline. She is interested in methods that can also help manage her dysmenorrhea. And she's wary of the idea of an IUD or an implant. She doesn't really want to have a procedure, and she just doesn't feel great about it. She will remember to take a pill daily, she thinks, and she just wants to talk more about what the different methods are like, how do they compare, what are things she should think about. So I think this is where contraceptive counseling still feels overwhelming, because there are just so many options. There's so many things to think about. There's so many different methods. There's just a lot of details. And so what's been most helpful for me has been to just choose a visual aid and to stick with it, so that in the room I can just, pull up Google and look for the chart that I use most often, and I'm familiar with it, and I sort of know the nuances of that chart. So I think that's something that's helpful just in organizing how much information there is out there, and also just a communication tool for patients as well. They may already kind of come in with certain ideas of what they're interested in, or maybe they've heard things from friends or family members, and so this way you can just sort of have it all out there and compare.
One quick question from the chat is just about if there are other language options.
Yes, I do. So there are certain websites that have different languages. Reproductive Health Access Project is one of them. And at the end of this section, I do have a slide of resources that hopefully you'll be able to you can maybe like write down the links, or you can just look at the PowerPoint later as well. Great question. Okay, so just a quick picture of the distribution of contraceptive methods among women of reproductive age between 2017 and 2019. So about 65% of women in that category were using contraception at the time. And you can kind of see the breakdown. So like female surgical options like tubal ligation, for example, and then there's the OCPs, which were about 14% of those women who were using contraception, and then about 10% were using LARCs, long-acting reversible contraception. And then about 35% were not using contraception for various reasons. And so back to our patient, what of the methods below fit Moira's goals? So again, her goals are interested in methods that can help manage her dysmenorrhea. She's wary of an IUD or an implant, and she feels like she could remember to take a pill every day. So this is just a poll here. Pick all that apply, and then we can go through it. And I'm not sure how, Javelle, do I just, how do we see the results? Or
Oh, I was going to give people another 5 seconds to vote.
Okay.
5-second votes, guys, and then I'll show it to you. Okay. There you go.
Great. Okay, so yes, I think we are on the right track. So she is looking for something. There's a couple of things that she's thinking about here. So she's looking for something that's going to help with her dysmenorrhea. And so when thinking about the options that we have listed here, barrier methods probably won't help with dysmenorrhea. However, it does address the fact that she's wary of the idea of an IUD or an implant. And so really, I think progestin-only pills and combined hormonal contraception are two options that might fit her goals as listed here. Obviously, with the copper IUD, that's not something that's going to help her dysmenorrhea, and also she's already expressed that she's wary of an IUD. Especially since she also feels like she will probably be able to remember to take a pill daily, and both of these methods can help with dysmenorrhea. These are probably the two that I would counsel her about. And just in general, I would usually reach for combined hormonal contraception first, just because with progestin-only pills, it's pretty finicky. You really have to take it within an hour of like the same time each day. And it can also cause irregular bleeding. So even though it might help with some of the symptoms of periods, it also can cause irregular bleeding. So often that's going to be like my second choice. And so just reminding ourselves how the contraception, how those contraceptive methods work. So the hormonal methods specifically can prevent or suppress ovulation, not consistently necessarily, but that's part of their mechanism of action. And then some of the hormonal methods can also thicken the cervical mucus, so things like the Mirena IUD, for example, and all those hormonal IUDs. And then both of those methods also will help thin the endometrial lining, and that's what helps, that's the reason that women will often find that they have lighter periods or that they don't have periods at all when they're on these methods. And then there's, the other methods, so for copper IUD, so it makes it so that the sperm I guess the word there is incapacitated, but they're just not really able to fertilize. And then, of course, the barrier methods as well.
There's a quick question
yes.
about, can you speak to migraines and the combined hormonal methods?
Yes, we will get to that. Great question. That's coming up. Okay, so next question. So based on this information and maybe your experience in clinic so far, what OCP will you prescribe? Great. Yes, they definitely all sound the same, and I don't know if that ever gets better. So the first line of combined oral contraceptives that generally like we use in the women's clinic, especially, and I think just generally, is the monophasic estrogen 20 micrograms and levonorgestrel 0.1 milligrams. And then also just in thinking about this patient in particular, we had also offered, the progestin only pill as an option for her. So just going through that, there's only like one option for that in EPIC, I believe. So that's easy. But with choosing the different types of OCPs, I'll go through this quickly here. So there's the hormones in these combined OCPs are going to be estrogen and progesterone, like synthesized versions of these. And so doses of ethinyl estradiol, there's different categories. So there's the low dose, which is 20 to 25 micrograms, medium, and then high dose, which is 50 micrograms, which is actually what OCPs used to have just all across the board. But, more recently efforts to decrease the amount of hormone that's in there. And then there's the progesterone component. And so it's broken up into different generations. And so I have arrows here just indicating, so increasing generations thought to be maybe more thrombophilic, and then decreasing generations thought to be more androgenic. And so, for example, with the fourth generation progesterones that you see, like with drospirenone, that's thought to be anti-androgenic, so good for people who have androgenic, like hyperandrogenic symptoms. However, in general, we will just start a low dose ethinyl estradiol, so 20 to 25 micrograms, and then a second or third generation progesterone. Usually it's just going to be like levonorgestrel or norgestrel.
Excuse me, sir. Box short. Yeah. Sorry. Oh, great. Thank you.
And then so there's another consideration here, which is whether the patient wants to use the pills cyclically or continuously. And that refers to whether or not they take that week of placebo pills or if they just continue taking hormonal pills during that placebo week. Both are okay. It just really depends on the patient's preference. Maybe some people appreciate that, having a period and sort of like reassuring themselves that they're not pregnant, for example. Or if they just want to get rid of their periods totally, then they can take it continuously. And so here we're going to start talking about contraindications and how we can look these up or, sort of like guide discussion during our patient visits. So what are some contraindications to combined oral contraceptives? Great. Okay, so we are saying history of PE and smoking greater than or equal to 15 cigarettes a day at age 35 or older. And then family history of breast cancer, yes, it's not a contraindication. And then diabetes with vascular complications actually is a contraindication, or it's at least something that should be considered for patients. And so the way that I just sort of help myself in the moment is that I use the CDC medical eligibility criteria app. And so just to quickly run through how it's used, there's a key which shows different numbers associated with the risk profile for each method and a particular health condition. So one method is safe to be used, 4 is unacceptable health risk, and then there's the 2s and 3s, which are basically areas where counseling is going to be really important. So for example, with headaches, it's broken down into just general headaches that are not migrainous, and then there's migraines without aura, and then migraines with aura. And so this information, and then you can see like across the row, there's the, it breaks it down into the different types of methods. And then there's also the I's and C's, which indicate like initiation or continuation of that particular method. So you can see that within the migraine section, there's, it's not contraindicated for patients who have migraine without aura, but combined hormonal contraception is contraindicated in patients with migraine with aura. And there's I think some discussion about this. I think across the board it's still sort of generally counseled as this is a contraindication. A lot of the studies that were done were probably at the time when combined hormonal contraception had the 50 microgram doses of estrogen. And so now that we have lower doses, I think there's maybe some thought that there's probably less of a risk here, especially if this is like really the only option that that's going to fit the patient's, parameters. And there's also additional, but on the other hand, there's also additional data that in general, patients who have migraines with aura, whether or not they're on contraception or hormonal contraception, are at increased risk of vascular disease or like strokes. So I think the relative risk profile, I can't remember the exact numbers off the top of my head, but with aura and on combined medication, it was like 6 times higher. And then if it was just migraine with aura but not on medication, I think it was like 3 or 4 times higher. And then compared to without aura, it was just like, I think 1.5 or something like that. So that's how they sort of break down this information. And this app provides the evidence as well. So there's, it's really easy to use. I would just encourage you guys to download it, play around with it so you get a sense of how to use it. The nice thing is that it's also broken down by method and by health condition. And so you can look at it both ways as well. Okay, so this is sort of what it can look like on paper. It's a little bit overwhelming, but the app makes it a little bit easier to see. And then just another consideration is just to make sure that the patient, you can be reasonably certain that the patient is not pregnant when you're starting contraception. And so urine pregnancy test, generally this should always be done unless, patient is in a same-sex partnership. And then just going through, there's this algorithm both in the app that I just mentioned and also like in UpToDate. So easy to follow, but just making sure that if the patient just had their period, then most likely we don't have to worry about them having ovulated, and then if they had unprotected sex, them being pregnant. But if it's been maybe like a week, 5 days to a week since they had their period, and maybe they had unprotected sex, then maybe we just need to be more certain that they are not pregnant when they are starting their contraception. So getting urine pregnancy test, but also just counseling them that if it's negative, it doesn't necessarily rule out early pregnancy. And so just discussing that with the patient, and maybe like, when you're doing your contraceptive counseling, if they haven't really decided yet, then just sort of giving them the heads up that like, if you do want to start at some point, just keep this in mind that we will want to try to make sure that you're not pregnant when you're getting your contraception, so that they can plan their timeline accordingly. And then emergency contraception. So we have 3 different types. There's the copper IUD. And so this is considered to be the most effective form of emergency contraception, and when it's inserted within 5 days of unprotected sex. And the nice thing about this is that, it's inserted and then they have their contraceptive method, or they have a contraceptive method that's already in place. They don't have to worry about starting contraception later if that was their plan. And then there's the 2 different hormonal options, which are the Plan B pill and the Ulipristal pill or Ella. So for Plan B, they come in various forms. There's like a 1-dose package or multiple doses. And unfortunately, with both of these hormonal options, they are thought to be probably less effective in patients based on their weight. And so for patients who are maybe like, greater than 180 or 190 pounds, probably the copper IUD is going to be the most effective. And then each of these have their own timelines as well. Plan B within 3 days, and then Ulipristal within 5 days. And then, there's a typo with this Plan B pill column, but basically you can start contraception right away for the Plan B pill, but you would still want to use a backup method for 7 days after taking Plan B. And then for Ella, you would want to hold off on starting hormonal contraception for at least 5 days after the pill. But then after that, they can start.
There's one question about Mirena used for emergency contraception. Addie wrote down that it is not used for emergency contraception. And then there's a question about recommendations for women who are perimenopause on OCPs. And we will get to that later in the day.
There you go. Great questions, everyone. Okay, so next, just go ahead and put in the chat, what are some things that make you think that contraception may fail, or the efficacy of contraception may be decreased? What are some things that you guys have heard about? Great. Use. They're not taking it. Yep. Weight. So BMI is actually something that I'm not sure if the evidence shows that. I think in general we think that probably it's effective for all weights, specifically with the hormonal, especially with the hormonal types of contraception. Medication interactions, yes, great. It's an issue for the patch. You're right. That is the one where we do think that it's probably less effective in patients with higher BMI. Anti-epileptics. Okay, great. So specifically, the CYP enzyme inducers can decrease the effectiveness of contraception. So with antibiotics, it's not all antibiotics. It's just the rifamycin, so like rifampin antibiotics that are thought to decrease effectiveness. And then certain anti-epileptics, so for example, like carbamazepine. And then there are certain ARTs, I think the ones that contain nevirapine, but I can't remember for sure. And then supplemental use, so supplement use like St. John's wort. And so if these are medications that the patient is on and it's important for the patient, then there are other options. So for example, the hormonal IUD actually is thought to continue to still be effective, and the shot and the copper IUD. And then we talked about typical use as well. So maybe just forgetting to take it or not consistently using the method. Maybe it's mistimed, or maybe it's just improper positioning for the ones that are like, like the ring or the patch, things like that. And so this brings me to my next point, which is that there is another option here, which is abortion. So that's something that I think in general, as internists, we don't necessarily talk about with our patients very regularly. I'm just curious if any of you guys as residents have talked with patients about the option of abortion, maybe when you're discussing contraception or you're discussing, preconception counseling, things like that. Okay, yeah, so I think this is something, this is just an opportunity for us as internists and as primary care doctors, at least for these 3 years, and if you're going to primary care later, just to think about, oftentimes abortion care is just sort of siloed, and it's not necessarily thought of as part of just like primary care or comprehensive primary care, which really should include comprehensive reproductive or preconception care. And I think that we can play a really important role in helping to reduce the stigma that's around this issue, even if we have different personal views. And so just a couple of times during a visit when I think we can consider addressing abortion. So especially during a discussion about contraceptive methods or reproductive goals, I think those are very relevant times to talk about the option of abortion, that, hey, even if this method fails and you are in a position where you're pregnant and you just really don't know what to do, like, please come talk to me. We can talk about your options, and I will, I'm sort of there for you. I'm a partner in your health, just sort of reassuring the patient that this is something that they can come and talk to you about, so that they're not just going on the internet and Googling things and finding out information that's sort of secondhand and maybe not accurate. So this little speech bubble here, just an option for language that can be used if you could become pregnant. You have a few options. Would you like to hear more about that now? So sort of inviting them to engage in the conversation. For some patients, maybe this is a really sensitive topic, or maybe they have really strong personal views. But actually there was a recent study that was done that was like a focus group of women who had varying beliefs about abortion, and across different political belief spectrums as well, or political identification. And even people who were strongly opposed to abortion, so that they wouldn't mind hearing about it during a visit. And this was a study of 50 people. They did in-depth interviews, but I think it's just worth offering as an option, because even if someone sort of identifies as one thing, things will change or may change later. So you can be a resource for your patients. Here are a couple of links, or just organizations that you can Google. And if a patient ever comes to you and is like, hey, this is the situation, these are some links that I would pull up. And these links will have lists of abortion providers, or just, some guidance about what are the next steps. And this is also just a plug that here at University of Washington, we do have family planning clinics. So there's one that's run by the family medicine department, and that's up at Northgate. And then there's another that's run by the OBGYN department, and that's here at the Roosevelt Clinic. And so if patients are within the system, or even if they're not, we can, they can be seen here. Okay. And then lastly, contraception and transgender patients. So this is an area of a lot of research. So far, like Tess already said at the beginning of our presentation, most of the research really has been done in patients who identify as cisgender. However, one important thing to note is that testosterone may not completely suppress ovarian function. So patients who identify as transgender and are on testosterone may still be at risk of getting pregnant. And if that's not in line with our goals, then that's just something that we should talk about with them. So okay to use all forms of contraception. It's not that there's contraception that would be made less effective by testosterone. I don't know of any particular studies, but this is just sort of the clinical practice guidelines that are floating out there. And then there's further information here. I provided a resource here just about what kind of language we can use, because this can be really sensitive a sensitive topic. So for example, even the word estrogen is a very sort of thought of as very feminine, it's a feminine hormone. So this can be challenging for patients too. So just thinking about what kind of language we're using and how we're naming things can be helpful. Okay, so this is that's the resource sheet that I was talking about that has the different, there's different languages. So I think Kevin had that question. So this is, I don't know, maybe you can screenshot it or something and use it as a resource, but these are just some of the links that are out there. I'm sure there's even more. There's so much information about all this stuff that's out there. But Reproductive Health Access Project really has comprehensive information and in a lot of different languages. Okay, so just to summarize some of the main learning points I'm hoping that we take away from this. So practicing shared decision-making by eliciting reproductive goals and contraceptive preferences, using open-ended questions, non-judgmental language, really making it a safe space for patients. Using a visual aid, so picking one and just sticking with it, and then also just referring to the medical eligibility criteria to help with counseling. Just remember to rule out pregnancy before starting contraception as well. And then first-line OCPs, lower dose estrogen, as well as a second or third generation progesterone, and then just considering when in your counseling or when in your relationship with your patient you might want to bring up the idea of abortion, if that's something that's relevant for them. Okay.
There's one question.
Yes.
Question is, would the estrogen and contraception affect the expected physical changes when someone's taking testosterone? It
could, and so I think that's why there's a lot of I don't know of, like I said, I don't really know of like specific data that I can point to, but it would make sense that it could affect. And so I think that's why it's important to have these conversations with the patient to just describe, you know, like, hey, this is the hormone that we're talking about. How do you feel about that? These are some of the things that might happen. Yeah, that's what I would say about that. Okay. So let's just take a little break, maybe like a quick little like five-minute break or something, and then we'll go on to our next topic, which is preconception counseling. So we'll see you at 9:42. Can you see my screen?
Yeah.
Okay, cool. Okay, hello everyone. I'll just get started here as people start to come back. So our next topic, we're talking about preconception counseling. Objectives here are to recognize opportunities to counsel our patients about this, and then also identify common medications that have teratogenic effects. Hold on, it's not clicking. Okay, so 10 years later, we are meeting Moira Rose again. So she is now 31. She, just a reminder, she has migraines. She presents to discuss depression. So she's currently not taking any medications. Substance use has increased. So she's drinking about 5 glasses of wine a week, up to 5 cigarettes a day. And then she's still sexually active with one male partner. She did have a medication abortion about 5 years ago that was uncomplicated, no issues there. So she and her partner do want a child, so she's no longer using the birth control pills that you had prescribed. And her PHQ-9 today is 11, and she's interested in starting an antidepressant. So what are some of the agenda items that you all would like to discuss at this point? You can go ahead and just put it in the chat if you want. Okay, so we are, oh, there we go. Medication options for depression, great. Substance use, smoking, great. Prenatal vitamins, love it, Hillary. Okay, so a lot of things that kind of fall under the bucket of preconception counseling, and just a little plug here that this also applies to male patients. We can also talk to them about contraception. But some of the things that specifically apply to Moira's case, so optimal management of chronic medical and mental health conditions, so her depression, moderate to severe with PHQ-9 score. Review medications and adverse effects. So she's interested in starting medication. How might that affect things, especially since she's thinking about becoming pregnant? And then talking to her about her substance use. And there's a lot of other things to think about as well. So, you know, the option of contraception, of making sure that we're screening for things like intimate partner violence, that she feels safe in her relationship. Thinking about like social support for pregnancy, and then especially if the patient sees a lot of specialists, making sure that those specialists are sort of looped into the discussion, encourage the patient to talk to those specialists as well. So here's a poll question. What would you recommend to Moira to help manage her depression? Check all that apply. Okay, great. So we're talking about starting an antidepressant medication and the sort of like lifestyle changes that we know can help with depression as well. Great. So this is exactly on point. The goal here is that since she does have depression, you know, at least moderate depression, and she's interested in starting medication, we would want to go ahead and start a medication. And so there are so just some guidelines in thinking about like when to treat conditions when someone's thinking about becoming pregnant. So especially with depression, depression can affect maternal, fetal, and child health. And so we definitely want to treat it, especially if it's something that the patient has dealt with a lot in the past. If the patient has maybe mild or no symptoms and they've been like very stable on like a low dose of an antidepressant or something, and they're really concerned about the medication affecting pregnancy, then there is the option to maybe try tapering off of antidepressants prior to pregnancy, but that would really just make, you know, you would just want to make sure that it's a very like shared decision making, and once again counseling discussion about it, and that there's close monitoring. So maybe you're following up with her like every 2 weeks or so, and just low threshold to restart medications if needed. But otherwise, if there's severe depression or there's other psychiatric comorbidities, so for example, like bipolar disease, or they're just on some medications that you know that might feel a little more unfamiliar, then that's when I would consider involving a psychiatrist. And then it's also safest, in general, it's just safest not to drink alcohol at all during pregnancy. I think there's, a lot of just sort of anecdotal counseling that where it's like probably okay to drink a little bit, but it's just difficult to quantify that. It's difficult to counsel about that. So just to reduce the risk, that's probably what I would recommend. Yeah. And then just thinking about medications that patients are on when if they're thinking about becoming pregnant. And so, you can find these lists online too, but these are just some of the common medications that we prescribe. So for example, ACE inhibitors, it's something that I often am forgetting to talk with patients about the fact that this can be a teratogenic medication. So do they know that, and what type of contraception are they using if they're interested? And then the antidepressant section here. So these SSRIs, other than paroxetine, they're thought to be probably safe in pregnancy. Sertraline is the one that's used most often, or just sort of thought to be safe because I don't really know exactly why, but for some reason it's just sort of used mostly. But paroxetine is one where it's thought that and you can see it's a class D as well for pregnancy contraindications. So probably one that I would either try to switch or just avoid in general. And then there's the anti-epileptic drugs, and then things like warfarin, that kind of thing, which all have teratogenic effects. And just a statistic that I felt was relevant to me in my practice, at least, was that contraceptive counseling is provided in only less than 20% of health visits that documented use of a potential teratogen by women of childbearing age. And so just thinking about every time we're prescribing any sort of medication, how might that affect a person's reproductive health? Just a reminder for this. And then there's a question.
If women do become pregnant while they're already on an SSRI, not paroxetine, do you refer them anywhere or keep them on their meds?
I haven't run into this issue, but if this were to happen, I probably would just keep them on their meds. And, also would just encourage them to establish with an OBGYN, as soon as they can. But especially if they're not on paroxetine, then I probably wouldn't mess with their medications unless they're like, I really don't want to be on this, and I've been stable for a long time. Then maybe I would think about starting to taper or something like that.
I can just add, generally speaking, this is Addie McClintock from the Women's Clinic. Generally speaking, if they're on something that's working, so even if it's like Wellbutrin or something that's not necessarily considered a preferred agent, they should stay on if they want to. It's much more, like Nina alluded to, it's much more important that she have well-controlled, or like be in a good place with her mental health during pregnancy. There's probably more harm to a fetus of uncontrolled anxiety and depression than there is for taking the medications, kind of aside from paroxetine. And then there is a perinatal psych consult that anybody can use. It's based at UW, but that is an option. I can look for the link and put it in, but that's available.
Thanks, Addie. Okay, so,
Nina,
yes.
I'm going to just repeat what Addie said because I think Gina couldn't hear.
So what Addie said was that in general, if a patient is already on an antidepressant, the general concept here is that you would probably just want to continue it. Even if they're on something like Wellbutrin, for example, that's not necessarily an SSRI, not as commonly, prescribed in pregnancy. We want to make sure that the depression is managed and treated. Another thing that Addie mentioned was that there is a perinatal psych consult that's available at the Roosevelt Clinic, and she'll put in information about that in the chat. Okay, so next topic, so prenatal vitamins, which was brought up in our chat as well. In general, pretty straightforward here. So 400 to 800 micrograms of folic acid daily, at least a month before conception. And then if at higher risk of neural tube defects, so for example, if patient or their partner has a history of neural tube defects, or there's a previous child who was affected by neural tube defects, then would want to consider a much higher dose of folic acid, so 4 milligrams daily, starting a little bit earlier as well. I think that this is often something that someone finds out that they're pregnant and then they start taking this, which is, that's just how it works sometimes too. But it is something where we can, if we're sort of aware of our patient's reproductive goals, then we can recommend this and they can sort of do it on their own timeline. And the reason that it's important to maybe already be on folic acid before someone finds out that they're pregnant is just because of the stages of development. And so within the first 8 weeks is when most of the most important organogenesis happens. And so just making sure that they're already on it when those processes are starting. Okay.
Question of how do we think about antimetabolites like methotrexate?
Yeah.
How long before anticipated pregnancy should it be stopped?
So methotrexate is teratogenic, and I don't have an answer for how long it should be stopped beforehand. And this is the exact situation where I would say whoever's prescribing that, so most likely there is a rheumatologist or pulmonologist or someone else who's involved. I would want to make sure that we're looping them into the discussion, because if it's something that's really important for their disease, then probably the timing is going to be really important as well. And Ruth has an example here it's usually about 3 months. But I think just in general, especially if people are on these types of medications, I would just want to involve the person who's prescribing that medication to help make the decision. Okay, so just to summarize what we have talked about for preconception counseling. So important to work with the patient to optimize chronic medical conditions, so diabetes, depression, hypertension, preferably before conception. And then when prescribing any new medication for any patient, just considering how it might affect their reproductive health. Folic acid, we talked about the dosing, and then encouraging involvement of patients' other providers for pregnancy planning. Okay, so we'll just push through to start abnormal uterine bleeding. So our objectives here are to define abnormal uterine bleeding, integrate the history and exam findings to create a differential, and then also begin workup and management for ovulatory AUB. So back to our patient. So we weren't able to get to anything more at our last visit, but she's back here again to talk about irregular periods. So she is now on sertraline that you started at your last visit. She's reduced her substance use, so down to 1 glass of wine a week, 1 cigarette a day. She's making some headway. And her reproductive health has not changed. So what are some things that you might want to know about her regular periods? And go ahead and type in the chat. Any signs of a high androgen state? Great. How far apart are her periods? Painful. Great. So we're talking about what are some associated symptoms? What's the timing of her period? Did she used to have regular periods? Great questions. Okay, so just a quick review of taking a menstrual history. So age at menarche, first date of last menstrual period, and any associated symptoms with their periods. And then also, this is a helpful chart that just helps me keep my data organized. So thinking about certain parameters. So they're going to be frequency, duration, regularity, and flow volume. And so the normal parameters are the rows that are in white, and then the abnormals are the ones that are in gray. So, for example, normal frequency or cycle length is going to be about 24 to 38 days. I generally just say 25 to 35 days, and then goes through duration about 7 to 8 days. Regularity is just how different the cycle lengths are, and then flow, heavy, light, normal, and this is really just determined by the patient. You can give them parameters like, for example, how many pads or tampons are you using, or really that are getting totally soaked through in an hour or two. That would be considered heavy. And then intermenstrual bleeding as well. Do they have any spotting in between their periods? And then if they're on medications, there's more specific questions there as well. And then this is just a little plug for period tracking apps, which are super helpful in helping patients and helping us understand what their cycle is like and what are some of the associated symptoms. I just had it, a lot of my patients will track their periods already, so we just pull up the data together and sort of go through it that way. So what's the basic workup that you would consider at this point for any patient who presents with abnormal uterine bleeding? So this is just anyone who, like, what's some of the basic workup that you would do? Doesn't have to be specific for different etiologies. Cool. Okay, so we have it all. So I think that the things that are probably just with like a basic workup, if someone's saying that they have, a change in their bleeding, I would probably at least start with CBC, TSH, pregnancy test, and cervical cancer screening, making sure that they're up to date there. The decision about coagulation tests, iron studies, and ferritin, and transvaginal ultrasound, I think, if those are ordered first, that's also totally fine. But in general, like, unless they're having heavy bleeding, I don't know if the coagulation tests and the iron studies would be all that helpful for me. And then the transvaginal ultrasound, if the history especially sounds like there might be a concern for some sort of structural abnormality, or we've sort of gone down the workup and still not really understanding what's going on, then this would be a helpful study.
Would you include prolactin?
Prolactin level, yes. So that's something that in general, like, you most likely could do with an abnormal uterine bleeding presentation, but also something that might be more specific if you're thinking about specific diagnoses within this bucket. Okay, so going back, we've collected a little bit more history here. So she started birth control pills at 17 years old because she had heavy and irregular periods. So thinking about, what were her periods like before? While she was on the pill, she had regular and light periods lasting about 5 to 7 days. And you do ask about PCOS symptoms. She does use a hair removal product, and on exam, you do notice that she has some nodular cystic acne, mainly on the mandibular area. And then more information about her periods. So about every 45 to 60 days, duration about 5 to 8 days. There's a lot of variation between her cycle lengths, and then she would characterize her flow as heavy, but she doesn't really have any spotting or intermenstrual bleeding. So at this point, does anyone have like a framework for their differential diagnosis of AUB?
Palm coin,
yes. Okay, great. And Laura, yes. So I'm going to present two different ways of thinking about this. First is what we have learned probably all in med school. We have palm coin. So this is a helpful way to break, just like remember the different etiologies that can cause AUB, and then also break it down into structural and non-structural causes. So structural, obviously, that's where a transvaginal ultrasound is going to be helpful, and non-structural are going to be a little bit more involved, making sure that we have the right history or comprehensive history, things like that. Another option for how we can think about this is to think about it based on symptoms. So in general, this is how these different diagnoses will present, but this is not necessarily always the case either. So sort of take this with a grain of salt. But with heavy or long periods that are still cyclical, maybe like a little bit still somewhat regular, we might be thinking of things like fibroids, adenomyosis. If they've always had really heavy periods and maybe they have a history of anemia, then thinking about coagulopathies. If there's bleeding between periods, often polyps will cause some spotting or just some bleeding between periods. If they're on contraception, certain types of infections, so STIs, for example, and then just also thinking about different cancers. With irregular periods and no periods, this is the point that Laura brought up. which is that we are thinking about probably this is some sort of ovulatory issue. So things that fall under this bucket would be PCOS, pregnancy, obesity, different endocrinopathies. So high or low TSH can affect this. And then postmenopausal bleeding. So this is a more specific age group or population of people. So then we're more concerned about malignancy. Is this caused by atrophic vaginitis, et cetera? So for just a little bit of a deeper dive into ovulatory dysfunction, I think we are sort of identifying that this is what Moira is dealing with. A couple different reasons for ovulatory dysfunction that have to do with all of these hormones, which might just be a lot, but basically just thinking about the hypothalamus and the pituitary and like adrenal axis and how it affects the ovaries and the uterus. So there's just, for example, if you have like a patient who maybe it has athlete's triad or something, then that might be a reason for ovulatory dysfunction. We talked about thyroidism, PCOS, and then ovarian insufficiency as well. So if someone's starting to show signs of menopause or earlier than expected, so earlier than the average age of around 50, then that's a consideration there. So the additional workup for ovulatory dysfunction would be prolactin. And then we can also think about doing FSH. But then we also want to do 17-hydroxyprogesterone, and that's just because adrenal hyperplasia can present similar to PCOS. So we don't want to miss that diagnosis. And then also free and total testosterone can be helpful. And then DHEAS as well, just to look at the sort of androgenic profile. Plus or minus transvaginal ultrasound it's not necessary for the diagnosis. It can be helpful in just making sure that there isn't something else going on. And then we can also think about doing progestin challenge, which I'm not really going to go into a whole lot today, but basically we're looking for whether or not the patient has a withdrawal bleed, and it can indicate whether or not they do have endogenous estrogen. But that's sort of down the line. So we'll just keep it basic for today. And then complications of ovulatory dysfunction. So with prolonged anovulation, then there's unopposed estrogen. So that increases the risk of endometrial cancer and hyperplasia. So that's just something to think about when patients have ovulatory dysfunction, that kind of puts us down a different pathway of things that we need to manage. So specifically with PCOS, we've sort of gone through the presentation already. So someone may present with irregular periods if they have, in general, maybe fewer than 8 or 9 periods a year. Maybe their first presentation is infertility. They've been trying to get pregnant, and it's been 6 months or a year. Hyperandrogenic signs, which we talked about, so things like acne or facial hair or hair that's thicker or just more prominent than others. And we would just want to differentiate this from virilization, which examples of virilization would be if, for example, there's really low voice, or there's rapid onset of clitoromegaly, for example, or male pattern baldness. And these are things where we want to think about androgen secreting tumors. And so just making that differentiation, and then metabolic syndrome as well. And then the diagnosis, we traditionally just use the Rotterdam criteria, so greater than or equal to 2 of the following. So we mentioned the oligo or anovulation, hyperandrogenism, which can just be clinically evaluated. It doesn't necessarily need the labs. And then also polycystic ovaries on ultrasound, but this is not required for the diagnosis. And we also went through the labs already earlier. So treatment, there's a couple things to consider here, which endometrial protection, if a patient has fewer than 4 periods a year, then we do want to make sure that we're giving them some progesterone so that we're sort of breaking that cycle of unopposed estrogen. And so there's a couple of ways of doing this. There's the hormonal IUDs. You can give them combined OCPs or progestin. And then for androgen excess, the things that will specifically address the acne or the hair growth will be the things listed here. So combined OCPs or spironolactone. Topical creams also work. And then if infertility is an issue, then weight loss of I think even just 10% or something has been shown to improve ovulation. And then there's other things which at this point you'll probably be, you will have probably already consulted a specialist for, so things like letrozole and clomiphene. Metformin is something that generally is just not really a first-line medication for PCOS at this point. It's thought that maybe it could improve ovulation, but it doesn't necessarily translate to like higher rates of live births. And in general, it's not necessarily a reason, just because someone has PCOS, it's not a reason to start metformin. So that's something that I would, and it also doesn't address the androgen excess or the endometrial protection. So it's not something that I would start in a patient with PCOS, with just PCOS, unless they were diabetic or even if they had prediabetes. Okay, so just to summarize what we've talked about for abnormal uterine bleeding, basic workup would be CDC, TSH, pregnancy test, making sure that cervical cancer screening is up to date, and then thinking about what other tests will you add on based on what you think the differential is for the patient. Irregular or no periods likely indicate anovulatory bleeding, which can also be associated with heavy bleeding. And then consider PCOS in patients who have signs of androgen excess and anovulatory bleeding. And then remembering that endometrial protection is needed if a patient is having less than 4 periods a year. Okay, any questions?
Question about, is it only for less than 4 per year?
Yeah, and I don't, maybe Addie or Megan, you guys know the data behind this. I don't know why that's the number, but that is sort of the number that we use is we want to make sure that they're having, a period a quarter, I guess.
Can people hear me?
Yes.
I don't know why that's the number either, to be honest, but I assume that that's just the amount of time, if you can have 4 periods a year, roughly, that demonstrates that you have some progestin exposure and that you're able to thin the endometrial lining periodically. That's really, really like whether she's having 4 periods a year or decides to go on contraception, it's all really in the service of endometrial protection to not have that unopposed estrogen and to sort of demonstrate one way or another that there's enough progestin to balance out that lining and keep it healthy and not too thick.
Oopsies. Okay, thanks guys. So we'll take another break here. Let's do a 10-minute break and then pass it off to Tess. Thank you. Oh, here, yes. What if I do that? Yeah, you see it. You see it. Okay, cool.